Welcome to the Respiratory Core 2017, the Difficult Airway. I'm Tim Jen, and I'm one of the residents of University of Ottawa. And today we'll be focusing on the couple of learning objectives. So Royal College requirement for the Canadian exam. We have difficult airway algorithm and current accepted airway guidelines, the classification into categories, specifically talking about the unpredicted difficult airway and applying the guidelines from difficult airway algorithms. So let's jump right into it. There are two relevant difficult airway guidelines in Canada. One of them is the ASA Practice Guidelines for the Management of Difficult Airway, published in 2013. And the other is the CJA Difficult Airway with Recommendations for Management, also published in 2013, which was separated out into Part 1 and Part 2, the unanticipated and the anticipated difficult airway. The definition of difficult airway is heterogeneous across literature. In ASA, they define it as when a conventionally trained anesthesiologist experiences difficulty with face mask ventilation, tracheal intubation, or both. And in the CJA guideline, they define it as when an experienced provider anticipates or encounters difficulty with any or all face mask ventilation, direct or indirect laryngoscopy, tracheal intubation, SGD use, or surgical airway. So, classifying the difficult airway into different categories, we have various definitions. ASA defines a difficult face mask ventilation as having inadequate seal, excessive gas leak, or an excessive resistance to gas egress or ingress. While the CJA defines it as having the need for head and neck adjustment, oral nasal airway, use exaggerated jaw lift, two-handed technique, or an assistant of a second operator. ASA defines difficult GA placement as a multiple attempts, while CJA is more prescriptive and describes as difficult access to patient's mouth, hypopharynx, difficulty in achieving a seal or ventilating a lung. ASA defines difficult laryngoscopy as cannot visualize any part of vocal cords after multiple attempts, while CJA specifically defines it as a grade 3 view for a difficult laryngoscopy and grade 4 view as a failed direct laryngoscopy, even if the intubation were successful. ASA defines difficult tracheal intubation as multiple attempts or operators, while the CJA is more prescriptive and defines that multiple attempts or operators using requiring adjuncts and introducers, requiring alternate intubation device other than the Plan A device. CJA also describes the difficult transtracheal airway as multiple efforts or excessive time. And for failed intubation, ASA defines as fails after multiple attempts, while CJA defines as fails with maximum of 3 attempts, regardless of techniques used. And finally, CJA defines failed oxygenation as cannot intubate, cannot oxygenate with a failed tracheal intubation, and cannot be oxygenated by a face mask or supraglottic device. Next, let's look at the specific difficult airway algorithms. As per the ASA guideline recommendations, these are some of the recommendations that they have mentioned. Number one, for airway evaluation, airway history, physical records should guide further diagnostic tests. And the basic preparation for difficult airway include the difficult airway card being readily available. And if there were known or suspected difficult airway, there are 4 steps that should be taken, including number 1, inform the patient. Number 2, having the assistance available. Number 3, pre-oxygenate via the face mask. And number 4, delivering oxygen actively throughout the airway management. Intubation strategy should be pre-formulated and assessing and addressing 3 main areas of concern. Number 1, addressing 6 potential difficulties, including difficulties in cooperation, back mask ventilation, supraglottic device placement, laryngoscopy, intubation, or surgical airway. Number 2, there are 4 main choices: non-invasive versus surgical, video versus direct laryngoscopy, throughout or apneic. 3 will be 3 clinical situations. Regional may be an alternative, but the definitive solution to the and does not obviate the need for reformulated strategy. And confirmation should be done with an end-tidal CO2 for a tube placement. Now, looking at the ASA difficult airway algorithm, they basically separate out into 2 parts: awake intubation and intubation after induction of general anesthesia. So awake versus asleep. The algorithm, basically, it's more useful if you go through it on your own. But basically, it says that if you have issues with face mask ventilation and intubation, then you should consider supraglottic airway placement. And if that fails, then move on to the emergency pathway by calling for help and trying to establish invasive airway access, which they define as surgical or percutaneous airway, jet ventilation, or retrograde intubation. Now, moving on, extubation strategy. It should also be a pre-formulated strategy, considering awake versus sleep extubation, clinical factors that may adversely impact ventilation after extubation, airway management plan if unable to maintain adequate ventilation, and short-term use of device such as exchange catheter versus conduit such as intubating LMA to guide expedited reintubation. So in terms of follow-up care, there should be documentation of difficult airway and reasons for difficulty, how intubation was accomplished, and implications for future care. We should inform the patient, document in a chart, letter to the GP or the patient and a surgeon, a notification bracelet, or flagging the chart for the difficult airway. We should also follow up with the patient for potential complications of difficult airway management. And complications could include edema, bleeding, tracheal perforation, esophageal perforation, pneumothorax, or aspiration. And also, we should advise the patient for signs and symptoms of life-threatening complications, such as sore throat, facial pain and swelling, neck pain and swelling, subcutaneous emphysema, or dysphagia. Now, moving on, one of the college requirements is the unpredicted difficult airway, and this is well addressed by the CJA recommendation of unanticipated difficult airway. So these are the most salient points. If you encounter bag mask ventilation in difficulties, they suggest first adding the oral airway and then use both hands, and if needed, release the cricot pressure slowly. If you encounter difficulties with supraglottic airway placement, then actually it just says in cannot intubate, cannot oxygenate situations, one attempt at the SGD should be tried. If you have difficulties with never mind.